Hello everyone, I am Jean-Louis Teboul from Paris. I'm very happy to give a talk on ScvO2 for the dummies right now. My conflicts of interest are on this slide. What is SvO2 is the first question I want to answer. SvO2 is the oxygen saturation of the mixed venous blood, which can be obtained at the level of the pulmonary artery using a PA catheter, for example. What are its determinants? According to the Fick equation applied to oxygen, VO2, oxygen consumption, equals cardiac output times the arteriovenous oxygen content difference times 10. So if we manipulate this equation, we can obtain the following one, as VO2 equals SaO2, which is the arterial oxygen saturation, minus VO2 divided by cardiac output times hemoglobin concentration times 13.4. Therefore, SvO2 looks like an indicator of the VO2-DO2 balance because DO2 is proportional to ScO2 cardiac output and hemoglobin concentration. A decrease in SvO2 can be due to a decrease in ScO2, which is a very important determinant of SvO2. Of course, if cardiac output does not compensate for the decrease, could also be due to an increase in oxygen consumption if cardiac output does not compensate for this increase, and this can occur in case of big stress, in case of fever, shivering, or use of thermogenic agents. This could be due to a decrease in hemoglobin concentration if cardiac output does not compensate for the decrease, or this could be due to a decrease in cardiac output. And this is the most important reason for a decrease in SvO2 in clinical conditions. So SvO2 is an indicator of the VO2-DO2 balance, and in shock states, a low SvO2 suggests insufficient oxygen delivery with regards to oxygen needs. Therefore, a low SvO2 might incite clinicians to increase oxygen delivery. What happens in case of increase in SvO2? This could be due to an increased cardiac output or a decreased oxygen consumption. And this decrease in oxygen consumption can be related to a decrease in global oxygen needs. This is what we can see in situations of profound hypothermia, for example, or mechanical ventilation with full sedation, or this can occur in shock states non-related to a decrease in cardiac output. For example, hyperdynamic shock states, for example, hyperdynamic septic shock, and normal or high SvO2 may exist in this kind of shock states. Another question is, does ScvO2 correlate with SvO2? ScvO2 is a central venous oxygen saturation obtained using a central venous catheter. And to answer this question, we have many studies in the literature. This is one of them, one of the first ones, published 17 years ago now, and Konrad Reinhardt was the first author. And the authors looked at an agreement between ScvO2 and SvO2. ScvO2 measured using a central venous catheter, and SvO2 measured using a PA catheter. As you can observe, there was a good agreement with a percentage error of only 11%. So ScvO2 is considered an acceptable reflection of SvO2. What about the trends? Here, a paper looking at the correlation of changes in ScvO2 on the y-axis and changes in SvO2 on the x-axis. As you can observe, there was a good correlation. And this paper, as all the papers, confirm that changes in ScvO2 can reflect changes in SvO2. And this is very convenient for the clinical practice because the use of PA catheter is declining, of course, and we use more and more central venous catheter, and we can obtain ScvO2 from this kind of catheters. Now, can we use ScvO2 as an endpoint of resuscitation? And this is a question which was addressed by this study by Rivers and co-workers, a very famous study published 20 years ago now in the New England Journal of Medicine in patients with severe sepsis and septic shock who presented at the emergency department. And this was a single-center randomized controlled trial comparing two strategies, one standard therapy strategy and one oligo-directed therapy strategy, EGDT. Both strategies use CVP, MAP, and renal output as endpoints, but the EGDT strategy also used ScvO2 as an endpoint. A target value of 70% was used. And interestingly, the mortality rate was lower in patients of the EGDT group in yellow compared to the control group in blue, and it was true for the in-hospital mortality, 20-day mortality, and 60-day mortality. So very, very impressive results. And this is why the surviving sepsis campaign guidelines recommended for the use of ScvO2 or mixed venous oxygen saturation as goals of resuscitation during the first hours of severe sepsis or septic shock. However, the last version of the SSC guidelines do not recommend the use of ScvO2, and there is no mention to ScvO2 anywhere in the 90th recommendation. This could appear like very surprising, but in fact it was due to the publication of three important multicenter randomized controlled trials, ARISE, PROMISE, and PROCESS, which compare in a randomized fashion standard care and EGDT. And as you can observe, there was no improved survival with EGDT, and this is probably the reason why the experts of the SSC guidelines remove ScvO2 from the guidelines. However, we should be very cautious about these conclusions, first because patients were far less sick than in the Rivers study, and also because their mean ScvO2 was already above 70%. It was the target at the inclusion time, probably because patients received a lot of fluids before inclusion, 2,500 ml on average. Therefore, by design, these studies could not show any benefit of targeting ScvO2 above 70% by design. And this study cannot tell anything about the utility of targeting or not ScvO2 above 70% when ScvO2 is low. And this can happen in 27% of cases, according to this study by Teboul and co-workers, study which included 365 patients with septic shock. Interestingly, in this study, the authors looked at patients with lactate and ScvO2 measured at age 6 hours after resuscitation. As you can observe, patients with hyperlactatemia. In these patients with hyperlactatemia, that is to say more than 2.2, there was a lower survival when ScvO2 at age 6 remained lower than 70%. So it makes sense to increase ScvO2 when ScvO2 is low. And this is why the experts of the ESICM, who wrote recommendations in a consensus way, consensus on circulatory shock, suggested measurements of ScvO2 to assess the adequacy of cardiac output and to guide therapy. And this was confirmed by this expert panel paper coming from the cardiovascular dynamics section of the ESICM. In this paper, we said that low ScvO2 may indicate insufficient global oxygen delivery in case of shock, and insight one to increase oxygen delivery. So now to use ScvO2 properly, I start with a patient with septic shock. Is either hypotension and mottling, increased capillary fill time, hyperlactatemia. So I recommend to measure ScvO2. if ScvO2 is less than 65–70%. Inadequate oxygen delivery is likely, and attempt to increase oxygen delivery is logical, mainly through an increase in cardiac output if hemoglobin concentration is not low. And this is why the experts of this expert panel paper recommend, in case of low ScvO2, to increase oxygen delivery. Now, sometimes we could have a high ScvO2 in the situation of shock, higher than 80%. It means that there is a severe alteration of oxygen extraction, and an attempt to increase oxygen delivery is totally illogical in this situation. And in general, when you have a high ScvO2 above 80% or 90%, it is associated with a high mortality rate, as shown in this paper by Pope and co-workers, compared to mortality rate in patients with ScvO2 lower than 70% and ScvO2 between 70 and 90%. And in this paper, the presence of ScvO2 above 90% was an independent factor associated with mortality. And now, what happens in situations where ScvO2 is between 70% and 80%, more or less the normal range of ScvO2? What should we do in these situations of normal range of ScvO2 and persistent shock? Should a further increase in oxygen delivery be discouraged? The answer is no. According to this paper we published some years ago with Viemone and others from my unit, we looked at patients in whom we gave fluids. And we looked at the subgroup of patients who increased VO2 after fluid administration, and this increase was by more than 15%. So by definition, VO2 increased in this group of patients, and this was due to an increase in cardiac index after fluid administration. And this, importantly, was associated with a decrease in lactate, so beneficial effects on tissue hypoxia. Interestingly, ScvO2 was normal before fluid administration, meaning that we obtained significant benefits from fluid infusion in spite of baseline ScvO2 of about 70%. How to identify these kind of patients who could benefit from an increase in oxygen delivery when ScvO2 is in the normal range? One good way to do is to look at PCO2 gap. PCO2 gap is the difference between the PCO2, the central venous catheter, central vein, and PCO2 in an artery obtained from an arterial line. So we have two situations: high PCO2 gap, higher than 6, or PCO2 gap lower than 6, normal value. And in this expert panel paper, we emphasize on the importance of looking at PCO2 gap, essentially when ScvO2 is within the normal range due to alteration of oxygen extraction. And PCO2 is less affected by impairment of oxygen extraction. In this situation, a high PCO2 gap higher than 6 could suggest that cardiac output should be elevated to improve tissue oxygenation. So in this situation, an attempt to increase cardiac output is logical in order to improve tissue oxygenation. In the other case, normal PCO2 gap, alteration of oxygen extraction is likely because of the normal ScvO2 and the presence of shock, and attempt to increase cardiac output is not an option in this situation. Now I would like to thank you very much for your attention.